Hello, my name is Chuma Eruchalu, and I'm a fourth-year medical student at Harvard Medical School. I'm excited to share our work from the Center for Surgery and Public Health at Brigham and Women's Hospital in Boston. Although digital access has expanded in the last decade, disparities persist in access to broadband internet, device ownership, and digital literacy. Previous research in the medical and surgical subspecialties revealed disparities in telemedicine access early in the COVID-19 pandemic. However, virtual visit engagement in the general surgery population has not been thoroughly explored. Thus, we investigated demographic disparities in the use of telemedicine compared with in-person consultation for new visits during and after the initial public health emergency period of the COVID-19 pandemic. We performed a retrospective analysis of new visits at an academic medical center during the early public health emergency period, phase 1, and the gradual reopening period, phase 2, which were defined according to policies affecting the provision of surgical care. On March 24th, 2020, an emergency order was issued mandating the discontinuation of all non-essential services and thus limiting in-person consultation. On June 24th, the Department of Public Health authorized the resumption of elective surgical procedures and in-person consultation. Age, sex, race, ethnicity, insurance, education level, primary language, and ICD-10 diagnosis were included in the final models. There were two comparisons in each phase: virtual visits, including both video and audio only or phone visits, compared with in-person visits, and virtual video visits compared with audio only visits. Our multivariable analysis demonstrated that during phase 2, Black and Latinx or Hispanic patients were more likely to have virtual visits than white patients, which was statistically significant for Black patients. Women were more likely to have virtual visits than men during both phases. Furthermore, during phase 1, Latinx patients were less likely to have a video visit than white patients. And during phase 2, older age, lower education level, and having non-English primary language were significantly associated with decreased video use. Our work suggests that virtual visits may help expand surgical access to racial ethnic minority populations. However, disparities persist in the use of virtual video visits. Health systems must develop policies to promote telemedicine access and digital literacy, expanding access to broadband internet, device distribution, aligning reimbursement incentives, and engaging under-resourced communities to develop culturally and linguistically inclusive telemedicine platforms will help promote equitable virtual care delivery. On behalf of my co-authors, I would like to thank the Journal of the American College of Surgeons for the opportunity to share our work in this forum.